I'll be talking about trauma approach based on an emergency physician's mindset. So we depend 100% on radiology in any form when we are dealing with a trauma case. Obviously, not a small trauma case when the patient comes in walking with a small ankle sprain. We're not talking about that category. We're talking about the categories where the situation is a life and death based situation. So trauma radiology is a very important topic that every emergency physician should know, be it a resident or a consultant or anybody working in the ER. So what are the available modalities in trauma for us as an ER physician? Is the bedside focus would be the first one, because it is the fastest and it provides real-time assessment. And also you don't have to move the patient much for getting this bedside focus scans. Next is the plain X-rays, which is used for screening of chest and pelvis only in trauma radiology. CT scan would be the gold standard going forward. Starting with the bedside focus ultrasound, we have fast and e-fast scans. As you all know, this fast scan is the most widely used scan in any trauma cases presenting to ER in the present day. So it was introduced in the 1990s, but it is now a standard of care in trauma. In fast scan, you have pericardial, right upper quadrant, left upper quadrant, and suprapubic views showing, the respective places of subxiphoid, Morrison's pouch, sphenorenal, and pouch of Douglas. A little bit in brief related to the specific views. To be clear, there is always a confusion among residents what probe to use when you're using a focus scan to see a specific views. For all the views in fast scan, a curvilinear probe is used, which you people, commonly refer to as the abdominal probe. So in right upper quadrant, that is the Morrison's pouch, also referred to as hepatorenal space. You can see the fluid between the liver and the kidney, whereas the left upper quadrant, you see the fluid between the spleen and kidney. Pelvic view or the suprapubic view is used to visualize the free fluid posterior to the bladder, whereas pericardial view or the subxiphoid view is used to identify pericardial effusion or hemopericardium. So these are the probe pointers and the positions for probe in fast scan. As I said, we use a curvilinear probe or the abdominal probe with the probe pointer being denoted by a green sign. Let's go step by step. This is a right upper quadrant view or the hepatorenal view. The first image is depicting a normal fast scan wherein which you can see the kidney and the liver and the border where there is no free fluid in it. This moving image, the video that shows a fluid which is anechoic. So you have hyperechoic, hypoechoic, and anechoic. So the free fluid always appears anechoic on ultrasound scan. You can see the fluid in the hepatorenal space in the right upper quadrant. Similar image in the left upper quadrant, you have spleen and the kidney that is looking normal here with no free fluid in between, whereas the second image is showing a free fluid, which is a positive fast scan. In the suprapubic view, you can see the bladder in the first image with a clear demarcation of bladder wall, which is a bright white line with the fluid in the bladder, that is the urine. Whereas the positive suprapubic view shows free fluid posterior to the bladder, which is a longitudinal free fluid. When it comes to the subxiphoid view, you're mainly looking at the pericardium. You're looking for pericardial effusion or tamponade. In the first image, it is a normal subxiphoid view showing a cardiac border with the liver when there is no fluid in the pericardium. Whereas in the second image, you can see a anechoic fluid again around the heart showing a pericardial effusion. Tamponade or not is decided by whether there is a RARV collapse. So extended fast is nothing but you are covering the chest along with the abdominal findings. So that is standard fast with bilateral lung assessment. In this, you are also looking at hemopericardium, pneumothorax, or cardiac tamponade. In extended fast, these two visions are added. That is the left anterior chest and right anterior chest. In this, you are using the linear probe or the ones that you refer to as the vascular probe. Here, you are not using the curvilinear probe. So the normal finding when you're looking at a chest in an extended fast scan of a trauma patient, you will see the lung point where you see the normal lung movement, lung border movement. If you use the M mode or the motion mode at this point, you will see a sky, ocean, or beach view, which we usually refer it to as the seashore sign, which is a normal lung sliding sign. If in cases you have a pneumothorax, you will have an absent lung sliding as shown in this image, which on M mode, which will look like a barcode sign. From focus scans, that is ultrasound, we'll move on to the X-rays now. In X-rays, the X-rays that are meant to be taken in a critical trauma patient are only two X-rays. It is the chest X-ray and the pelvis X-ray. So there is a lot of importance given to X-raying AP view for long bones during trauma resuscitation, which is not right. If you have some long bone injuries, let's say a tibial injury or a femur injury, and if there is actively bleeding, The exsanguinating bleeding will be controlled in the first step of ATLS guidelines itself. There is no absolute advantage of imaging a long bone in the middle of a trauma resuscitation. You have to give importance to the focus scan, that is fast and e-fast. And after the focus scan is done, you move on to the X-ray series. In this X-ray series, you move on to the chest and pelvis X-rays, which are notorious for major injuries that can cause high mortalities. So when you approach a trauma chest X-ray, you can follow the ABCDEF approach. That is the airway approach, wherein which you can see the tracheal deviation. If you've already intubated the patient, you can see the ET position. Under breathing, you can see pneumothorax, hemothorax. Under circulation, you can see mediastinal widening, which can be a factor that can tell you there is a blunt injury to the aorta, which is a dangerous situation. Diaphragm movement. And under E, everything else. That is all the fractures, foreign bodies. And F is fields and soft tissues for surgical emphysema. So pneumothorax is one of the most commonest finding when you have a blunt trauma injury to the chest. So in most cases, like I said, first you do the fast scan. In some cases where the patient has a subcutaneous emphysema, or if the patient is obese, or if the center that you're working in does not have a focus scan, you rely on X-ray images to diagnose pneumothorax. So in some cases where the pneumothorax is subtle, or when the patient is obese, you may not find a clear-cut demarcated pneumothorax on X-ray. So you have these 5 subtle clues to occult pneumothorax, wherein which you can see these clues and you can suspect a pneumothorax in such a case. One is the deep sulcus sign, and you can always look for a visible pleural line or a hyperlucent hemithorax with absent lung marking, or as you can see in the last image, there is a tension shift, which is a tension pneumothorax. So in supine patients, pneumothorax may collect anteriorly and it may be almost invisible. The other X-ray in the X-ray series belongs to the pelvis X-ray. So you do the chest X-ray and then you directly move on to the pelvis X-ray, because pelvis bleeders are always the silent exsanguinators. You have a trauma patient who is conscious oriented. You have done a fast scan, you have done a chest X-ray, and still the patient is having hypotension, tachycardia. Always and always suspect the bleeding to be in the pelvic region. So pelvic X-rays, you cannot obviously see the bleeding, but you can see the fractures like open book pelvis fractures or vertical shear injuries, pelvic hematomas, or any of these injuries can give you an idea that it's an active extravasation and you have to consider a pelvic bleeding. So immediately, stabilize the situation by having a pelvic binder. So you did focus first, and then you had the chest X-ray series and the pelvic X-ray series. After focus and X-ray, we move on to the CT series. The one golden rule of trauma management and trauma radiology is you do not do a CT scan on an unstable patient. So you have a patient that is unstable, you have a fast positive or a e-fast positive patient, the patient directly goes to OR, that is operation room, or interventional radiology based on if you're suspecting a pelvic bleeder. So CT is only and only kept for people of trauma who are clinically stable. So in neurotrauma, ER must know things that you should know as an ER physician is an how to identify epidural hematoma, subdural hematoma, subarachnoid hemorrhage, intracerebral contusions, diffuse axonal injuries, and skull fractures. So any patients presenting with to you with a GCS of less than 15, with more than one episode of vomiting, loss of consciousness at sight, seizures, or obvious fractures you're suspecting, you have to go for a clinical imaging. A very simple slide, but a very important slide on ED survival of how to identify bleeders when you're doing neuroimaging. I would clearly tell here the EDH would be the most important surgical emergency that you would encounter as an ER physician. EDH, that is biconvex image that you see, easily referred to as idli by ER physicians to easily remember the shape of an idli. Whereas the other imaging that you see commonly in traumas is a subdural hematoma, which you have a concave or convex. Then you have other images where you have bleeding in the brain that is, in the ventricles, that the intraventricular hemorrhage, subarachnoid hemorrhage, where the blood is in the sulci or the cisterns. So you can have any of these findings when you do a CT scan of the brain of a patient in trauma. So from brain or head, you next move on to the chest. Chest, you have already done a fast scan, you have already done a X-ray series of the chest, but in CT, you can have some positive extra findings that you would not have found out in the X-ray series. Like slight small pneumothoraxes can be found out on CT, anterior air collection will be present, whereas in a hemothorax, you will have hyperdense fluid in the pleural space. Small pulmonary contusions will be seen as ground glass appearance or consolidations. Aortic injuries are very important and can be diagnosed very well on a CT, which will appear as a peri-aortic hematoma or an intimal flap. For rib fractures or flail chest, you can have a 3D reconstruction of the CT, which images I'll show in the next slide. Cardiac tamponade pericardial effusion can be found out. And tension pneumothorax should always be a clinical diagnosis. You are not shifting the patient for a CT to diagnose a tension pneumothorax. So these are some of the CT images in the CT series. In thorax, you can see some rib fractures. This is the 3D reconstruction of the thorax. And you can also see some unilateral hemothorax here and here as well. Some scapular fractures. Never miss spinal fractures when you're doing PAN scans. That is the trauma imaging. Never miss spinal cord injuries. As we saw in the last class by Dr. Aparijita, it can be very important. It can be life-threatening, and it can make the patient suffer for a long time in the coming days. And in the chest CTs, this is a scan with multiple findings. You have rib fractures, you have a pneumothorax, you have a subcutaneous emphysema. All in all, a good CT thorax series. From thorax CT series, you move on to the abdominal CT series, wherein which abdomen is full of all solid organs. You can expect an injury to any organ. Again, in the first step, when you're doing a fast and e-fast scan, if you have a positive fast scan and the patient is unstable, the patient directly go to the operation theater. But if the patient is stable, then you are doing this abdominal CT. You can expect an injury to any of these solid organs like spleen, liver, kidney, pancreas, bowel, mesentery, or even pelvic fractures. And any solid organ can have a laceration. I'll not go in detail to the grading. As you would know, there is a grading of laceration for spleen, liver, kidney, based on which you decide on conservative or surgical management. So what is important apart from all of these things we have already discussed now? Spine and pelvis are high stake injuries in trauma. Spine is, I would say, as an emergency physician, is the most ignored part in a trauma, because you have open, pelvic injuries, or you have bad femur injuries, long bone fractures where there is active bleeding. Spine is always something that takes a back seat in terms of you seeing the wounds or you seeing the injuries in terms of examination. So you should always think of spine and pelvis as high stake injuries because they often can get missed. So cervical spine, in first step of ATLS, you always immobilize the cervical spine first, and then you do a CT series if the patient is stable. Previously, it was a habit to do a cervical spine X-ray. Like I discussed, after POCUS scan, you move on to chest X-ray and pelvis X-ray. Previously, it was also a point to make a C-spine X-ray, but there is a huge difference in sensitivity when it comes to the imaging of C-spine. C-spine, you cannot do more than stabilizing the C-spine with a collar. So it makes no point depending upon a cervical spine X-ray alone. Instead, you can stabilize the C-spine with a collar and then move the patient to a CT when it is stable. Then plain X-ray pelvis series, you have to look for pelvic ring disruptions or open book fractures, because these kind of fractures can denote up to a 3 to 4 liter of huge fluid blood loss, which can land the patient up in hemorrhagic shock and causes high mortality. Once the patient is stabilized, you can then move on to CT pelvis. The key clinical point here is if you have an unstable pelvic fracture or any unstable injury with hemodynamic instability, you have to stabilize the patient and move the patient to interventional radiology or surgery. You should never delay for a CT. So to conclude or summarize, how do you manage a trauma imaging as an ER physician? This is the algorithm you can follow. The patient arrives in ER. You start with your initial assessment according to ATLS protocol. Then you see the hemodynamic status. Irrespective of the hemodynamic status of the patient, you have to subject the patient for a fast or a EFAST scan. If the fast or EFAST is positive and the patient is hemodynamically unstable, the patient directly goes to OT or interventional radiology. If the fast or EFAST is negative, then you can perform further tests like CT, chest X-ray, span scans to find out the exact spot of injury and to grade the injury what you're looking at. Then finally, you have a diagnosis and plan. Then you have to integrate all the findings that you have and then plan. So one important thing that you have to note here is in a stable patient where your fast and EFAST were negative, your X-ray series were negative, after doing a CT, you can still have a 30% change in plan. That means in 10 patients, you had 10 patients with negative fast, negative EFAST, chest X-rays are negative, patient is stable. You've subjected all those 10 patients for a CT scan. After the CT, 30%, that is 3 patients, can still have a change of plan because the CT picks up something. But there are some pitfalls to every trauma imaging, despite having all the advances that we have. That is, the fast and EFAST should be used only as a screening tool. It's not diagnostic. So you have to always correlate clinically to the condition of the patient. Tension pneumothorax is always and always a clinical diagnosis. As you all know, if you have all done ACLS, tension pneumothorax is one of the causes under 5H5T for cardiac arrest. So you should not wait for a chest X-ray or a CT to diagnose tension pneumothorax. Lung sliding on EFAST virtually rules out pneumothorax. So one of the major causes of mortality, immediate mortality, can be pneumothorax leading to a tension pneumothorax. So if you establish good lung sliding on both slides, you can eliminate a pneumothorax as a finding and you can move ahead. If you have an obese patient, fast scans may not be very much reliable on, or if you have a subcutaneous emphysema, then it may obscure the lung sliding and EFAST may be unreliable. If you have pelvic fluid in any of your scan, always think bladder rupture or any gynecological source. Stabilize the patient, start massive transfusion protocol if you need to, and immediately shift the patient to OT. So to summarize my class finally, as an ER physician's mindset in trauma radiology, how you should process a case. The moment a case comes to the ER, start ATLS protocol and start stabilizing the patient. The first imaging of choice should be your ultrasound bedside focus, which will have fast and EFAST for speed and it will give you good maximum information. Parallelly, you have to ATLS stabilize the patient and you should be a master of all 6 EFAST views. You cannot afford to miss a finding. Then along with this findings of fast and EFAST, you have to use your clinical judgment to correlate the findings. You cannot know CT scans like a radiologist, but there is no excuse to not knowing basic findings on a CT scan. You should be able to find out EDH and SDH and difference between the two, some CT findings of hemothorax, pneumothorax, or some abdominal bleed, laceration to liver and spleen. You should be able to identify. If the patient is stable, don't leave it there. Always depend upon serial reassessments via scan and also clinically.